Great name, too.
Buds with Suds. Yeah.
Great name.
Yeah.
Explosion.
Okay, welcome to Buds with Suds. This is Richard Zombeck. I'm here with Steve Lesnikoski. We are there. He is. We're in an undisclosed remote location today. Before we get started, I want to get a little housekeeping things out of the way. Make sure you follow us on Twitter and like us on Facebook, and you can find links to both of those on budswithsuds.com. Also, if you have any questions or comments or would like to come on the show, you can email us or even call us and leave us a voicemail from there. And don't forget to subscribe to iTunes, and you can get on the mailing list. So I think that gets rid of all the housekeeping stuff.
Sounds
right?
like it.
Yeah. So in this episode, I interviewed Mark Kennard, who is the former executive director of Project Cope in Lynn, which later merged with Bridgewell. We talk about a little bit of the history of Cope from the 70s on up, and he gets into a little bit of his background and the creation of Project Cope and the stuff that he's done over the years.
Yep.
So let's have a listen to that, and we'll talk about it on the other side. All right. Well, we can get going.
Let's do it.
Okay. So Mark Kennard, welcome to the show.
Thank you.
Welcome to Buds with Suds. We were just talking about the name a little earlier. I often wonder if people are going to get it, but so far we haven't had a problem, and we've gotten some good feedback. So Mark is, well, why don't you tell them who you are, Mark?
Just to comment on Buds with Suds for a moment.
Oh, sure.
So being someone that's been in the addictions treatment and recovery field for 40 years, it did take me a few moments to get it. So your average listener may or may not get it quickly, or just a reflection on my
that could be a whole different issue.
Right, mental quickness at this point. So I'm a retired, I think they call me a nanny now, or manny. So much of my time now is spent taking care of grandchildren.
Nice. That's a good show, too.
Offers an opportunity to reflect on many things. But prior to my retirement, I spent, as I mentioned before, many years in the addiction treatment field, much of it running a nonprofit in Lynn by the name of Project Cope.
Does that stand for anything?
It actually does. It was one of the 1970s acronyms, which were very popular then, and it took me a little bit of digging around years ago to find out that it's an acronym for Concern of People Everywhere.
Oh, nice.
I was never a fan of the name, and in fact spent some periods of time off and on trying to get it changed. In fact, we had moved to Recovery Resources at one point about 20 years ago. But the brand was surprisingly durable. And it just stayed. It beat me. It outlived me.
Well, you've never been a really kitschy guy.
No,
so.
I have not. So it's probably
it
was a good Cummins for me So Project Cope, which was one of these fledgling nonprofits that grew up in the 70s as a result of the lack of resources for treatment. In this case, in downtown Lynn. For people that were using and abusing heroin and basically had no place to go. There was a small group of concerned citizens, one of whom was a pediatrician, that were particularly interested in helping this population. They started a walk-in clinic in Central Square in Lynn, and from that grew an organization. They bought a building, which was an old funeral home that had relocated into Swampscott.
The one that's on Silsby, or?
No, the one that's on North Common Street.
Okay.
And managed to get, in fact, one of the founders, Dr. Ted Duchan, who I spent a lot of time with and got to know very well over the years, really a remarkable Swampscott pediatrician who has been so committed to recovery and treatment for decades. used his own mortgage as collateral to buy the building.
Wow.
And then they went and got a state contract for a residential program and started a residential treatment program for substance users. It was a year-long, very structured program, really called the Therapeutic Community, or TC at the time.
So detox as well, or?
No detox.
Okay.
It was up to a year, 12 to 18 months of intensive inpatient recovery. Very much of a TC model, which at that time the philosophy was that in essence heroin addicts or substance abusers were either bad people by the core or had learned bad habits, and in order to rid themselves of these habits had to be kind of stripped down to their basic core and then rebuilt
so like
differently.
A boot camp.
Yeah.
Emotional and mental boot camp.
And it was interesting, Richard, because for many people, and we kind of look at that now and we say, oh my God, I mean, these
Barbaric.
people. Yeah, that people, they're broken enough.
Yeah.
I mean.
Well, we know that now.
Right.
I mean, the 70s was really the advent of not the recovery movement, but the addiction treatment movement. Right. Where everyone started getting, they actually didn't, isn't that about the time when they started actually creating degrees and educations around addiction treatment?
Yes.
Right. And look where we are today.
Right.
We'll get to that in a minute.
We will indeed. What I was going to say, though, that it is surprising to me that the numbers of people, although I have to say predominantly men, so the residential program was, I think there were like 18 male beds and maybe 6 female beds. So it was a co-ed program. But many men, not so many of the women, really flourished under that kind of system, that kind of structured system. And this was classic in you did something wrong, inappropriate, outside the limits. You were given a toothbrush and told to clean out a storage cabinet and spend
I may have had a friend
8 hours
that went
doing
to that.
Yeah.
Yeah.
You had to wear signs. I stole blank. I'm a bad person.
So public humiliation.
Exactly.
Back to the stockades. Right?
But I had many people, because when I first came to COPE back in the early 80s, there were still vestiges of that program. And I remember having discussions with many people who really felt as though that particular approach did save their life. So the theme, one of my themes as a long-term treatment provider, is that we really need to be open to all different kinds of approaches. And I think, and I'll talk a little more in a little while about our kind of moving down to women's inpatient treatment, is that one of the egregious mistakes that I made was not understanding the damage that kind of approach could have on women who were in treatment, especially. Do
you think it? I mean, you said it worked a lot for men, but I can understand the
some men.
Yeah, I can understand the theory around it being more detrimental to women than men. But I mean, I'm sure there were some men that found it.
Yes.
Egregious as well,
Absolutely.
right? I mean, the thing is that there's still stuff like that now, right? Places like the Plymouth House, not as rigid, but it's still a rigid program where it's a 12-step program that you're indoctrinated into this way of thinking, and it's worked extremely well. I mean, they have cookouts and get-togethers once a year where there are thousands of people that are alumni of any of the Plymouth House and their kind of offspring. Right, the Ryan House, the so-and-so's house, all that have that same kind of model, right? So I'm sorry.
No, it's. I agree, and I think one of the elements of that always concerned me was the people who one that didn't work for. So that was often acted out in some ways that was not working. And then, they were just kind of removed from the program as being a detriment to the health and welfare of the other residents, and without really very little regard for what was going to happen to them. And when you now look at a time when it is so dangerous to be actively using, especially opiates, we can't afford just to be kind of throwing people out of treatment unilaterally for not obeying without any kind of real plan in place for the next level of care. And we were doing that. And in essence, it was really sacrificing a person for the good of the program was kind of how we rationalized it at the time. And my approach now, I think, is very, very different as I think about treatment.
Well, and you still see that in IOPs and
Absolutely.
PHPs, and there are punitive measures.
Absolutely.
And if you don't talk to someone, or if you don't go see this therapist, we're going to take your kids away, or we're going to call DHS, or I always get those initials wrong. I'm hoping I did that time. Or if you're in an IOP and if you use that week, you can't come back. You're going to have to start all over again. Or doctors who stop prescribing Suboxone because that person drank during the week, and it's like, what are you doing?
Right.
You and I have done Schwartz rounds together. So in full disclosure to the listeners too, Mark and I have done some Schwartz rounds at the hospitals on the North Shore, which are basically events around compassionate care, right? Does that pretty much sum it up? Or
I think that's an element of it. The more interesting element for me was to be able to have people reflect about how, in this particular case, what we were talking about was really dealing with people with substance use disorders, to understand their own reactions to their own personal reactions to that population, and then how that affects their ability to be a caregiver.
Right, and the reason I brought that up is because I often use my mother as an example, who's a diabetic, and give that example of like, well, look, if you had a diabetic that came into your ER and had an insulin reaction or was in a sugar coma, like my mother often is because she can't seem to regulate her sugar or her insulin, right? Would you throw her out on the street? Right. And giving that kind of, sometimes it works, sometimes it doesn't, sometimes people roll their eyes. But I think the majority of the people that we were addressing, which were nurses and clinicians, kind of got the parallel of like, what are you doing? These are sick people and they need to be treated like sick people, right?
Yeah. Yet, to connect that to treatment providers, non-medical treatment providers, we're doing the same thing. We're doing the same thing. Don't obey the rules, you get thrown out.
Right, exactly. Well, like the example of IOPs and PHPs and stuff
without
like that. And
really,
sober houses.
And very easily rationalize our doing that. This you didn't. You used Richard, so you can't stay here. You endanger the life person. Well, you endanger the lives and welfare of the other clients. So you must be removed. And I think that's really something that we really need to kind of reconsider in terms of how we address those kinds of issues. So I think hospitals are extreme cases often of that.
Yeah.
And they're afraid. They wouldn't throw your mother out because fear of litigation.
Right.
Yet there doesn't seem to be that pervasiveness. There's no fear of
well, it's just a junkie.
Throwing a, quote, junkie out.
As much as people hate that word, I apologize to anyone who's going to email me and tell me what an ass I am. So we'll just leave it there.
Well, I think language is important.
Yeah, I think it is too. And I think as a society, we're straying away from a lot of languages because we have this idea that it hurts people or it offends people. And I'm sorry, but if you're offended by it, I think you need to look at why you're offended by it rather than why I'm offending you, So I did a whole article up on Recovery Binder about that term, about the term junkie, its origins, the oversensitivity around it, and not calling yourself one, right? And I know that I referred to myself for the first 2 years in sobriety as a drunk, because it was self-deprecating, and I needed that. And if someone wants to call themselves a junkie because they need that in order to maintain their sobriety and continue their recovery, and maybe they need to flog themselves for a couple of years over something, then have at it. Let them be. But anyway, sidebars notwithstanding.
I do not disagree with that.
Yeah, okay. All right. Okay, so let's get back to. Oh, go ahead.
Well, in that case, the language drunk or junkie, it cuts through so many of the kind of intellectual defenses, and I think often people in early recovery really need to be in a place where that's often cut through, where it's a core reminder of who you are and kind of what you have, and then how you have to manage that.
Right. And as you know, I'm a big fan of etymology and the origin of words and phrases and stuff. And junkie was from the 1930s and 1940s of people who collected copper piping and to make money, right? So they were very industrious. They were collecting junk, right? And they were referred to as junkies. And it was to feed their families, to feed themselves, to pay their rent. And then, of course, drug users from opium dens and people that were using heroin caught on to it, so that they started maybe not collecting as much junk, but stealing it or ripping it out of basements and stuff. And the term stuck with them, right? So there's a whole, when you look at what people get offended by and you look at the history about it, right? And again, this is definitely a sidebar, but it's like suffragettes, right? I had a discussion with a woman who was very offended by the term suffragettes, and she said they're called suffragists now. And my point to her was that the suffragettes were called that by a New York reporter in a pejorative way. And in order to get over that, they took it on as their own, much like the queers did in the 70s and 80s, right? People called people queers, and they went, fine, we're going to own it, right? So it doesn't help to go, oh, well, that offends me. That term offends me. It's like, yeah, well, get over it. Let's look at the history of it, and let's find a better way to deal with this than you complaining about being offended.
Interesting.
My two cents, and as you know, I have a lot of them.
You do, and that's what makes you who you are. I was just, as you were talking, I was just reflecting on, because, so I came to, I graduated from Columbia School of Social Work in 1980, and then worked with the developmentally disabled for several years, and ended up moving to the North Shore and took a job in protective services, from which I discovered that although I was good at it, really the nature of that, and whether or not it was because I had two small children of my own then, or just kind of my personality, but that it just ripped my soul into shreds, and it really created a situation that was unsustainable for me. So I ended up in addictions, in kind of an odd way. I want to go back just a little bit. Sure.
I mean, I'm always curious how people get into something, but how was that a choice?
As I think about it now, when I thought about it then, it's very different than as I think about it now. As I reflect back from now, it really was opportunistic. That it was clear to me that protective services, again, I was getting a lot of kudos for my work, but was suffering immeasurably, as well as drinking to a vast excess personally, in terms of really self-medicating myself from and that was, going to court, taking children away from their families, dealing with people whose children I had taken away from their families. If you've ever experienced going into someone's home with the police to remove their children, and what that whole scene must be like, it's a devastating scene, and so that's. I think from that world, I was really offered an opportunity to direct a couple of small community-based programs that dealt with teenagers who were using drugs and alcohol, one in Peabody and one in Salem. And I kind of leaped at it as an opportunity to kind of move away from protective services. So then found myself in the addictions field. These programs both had contracts with the state to provide outpatient drug treatment services. So, per typical of my professional career, despite knowing nothing about it, and at the same time myself self-medicating to an unhealthy degree with alcohol, none of that seemed to serve as a barrier for taking the job. So I took the job, learned on the job. At that time, and I was working for North Shore Children's Hospital at the time, they were very progressive, small, it was really a small inpatient children's hospital with very progressive administration. They really saw the potential for outpatient services, both medical and behavioral health, and began to expand rapidly. Took an entire floor of the hospital and transferred it from a med-surg floor for kids to behavioral health. And they were interested in the future of addictions treatment. So that was the early 80s. If you remember, that was Reagan elected president. There were all kinds of concerns about funding cuts. Proposition 2.5 had taken place. That vote had taken place in Massachusetts. So there all of these programs that were funded by local municipalities were being cut. So it was a lot of cuts to treatment and prevention that were really kind of dictating the whole model shifting. So Project COPE, which was a small, and I described a little history before, a small nonprofit now operating. So they've now been operating about 10 years in Lynn, really saw the handwriting on the wall for them in terms of funding. So they decided to merge with an institution, a hospital. So it was a merger. They held hands for a while, and but the hospital was interested in expanding their outpatient services. I think COPE was interested in maintaining its financial solvency. So it was a good merger. And an interesting merger in that you have and as Richard is one who works for a healthcare institution, appreciate this. So, there's very much of a hierarchical model in healthcare. And when you mix that with, that kind of medical model with the kind of community-based nonprofit model, it's a very interesting culture shift.
Yeah, well, there's a basic explosion
right
at the center.
And then when you add people, when you add recovery into the middle of that, and the population, and often the staff of the nonprofits, who are many in recovery themselves, it's on many different levels. There's a whole kind of cultural dynamic. So that was really getting kind of played out in a couple of interesting ways, but they merged. I was kind of in the middle of it, working in a hospital and directing these two small programs. And then, unfortunately, the healthcare system, North Shore, ran into some serious financial difficulties and went bankrupt. And the net result of that was a lot of changes in that system. But for me personally, it was ultimately, do you want to continue to work for the hospital in some capacity, Mark, or do you want to kind of work with these people in Lynn, these copies, that no one really kind of understood but tolerated. And I, without really much deep thought, said, I want to go to Lynn. There was something really interesting about the work they were doing, how they were doing it.
So it wasn't so much a cerebral decision.
Not at all. Not at all. These are really interesting people doing some really kind of edgy things, and I really liked the population they were working with. So I went to Lynn, and people. It was funny. People at the hospital couldn't believe it. Columbia educated social worker, leaving that system of care for this kind of crazy community base with these bunch of drug addicts, and the staff were as weird as the clients. They had no money. Like, why are you doing this? But it was really it was a great affinity for the work and the people, and I think that. And I didn't have a lot of knowledge at that point. Unlike you, I kind of learn by watching and doing. My learning isn't a lot of textbook learning. It's much more intuitive.
I would say that you and I are very similar.
Then I don't want to project that.
No, you and I are very similar in that respect. I tend to throw me into a situation and let me learn it.
Yeah.
I've never been one. I mean, I'll obviously I read and I'll look things up, but only to one, to satisfy my curiosity, and to help me get the job done. I mean, I don't think I learned to add or subtract or multiply in my head until I was 35 years old and playing darts in a bar.
There you go.
You know?
When you had to do it.
It was by necessity.
Exactly.
You know? And my father was a mathematician and an astrophysicist and couldn't understand why I hated math as much as I did because I saw no use for it. But as soon as I had a legitimate use for it, I learned it. So
my learning story is that and when I was in graduate school, I was always interested in the kind of administrative management aspects of things, as well as the clinical. I did a lot of clinical work and always did clinical work. But I really liked administration. So I had been in this position at Cope. I was director of, they made some position for me. I was director of substance abuse services or something. Working for a woman by the name of Dorothy LeBrasser, who was really one of my two mentors, who was an incredibly bright and talented and creative woman who taught me a tremendous amount, much of it painful. But I think those are in some ways for me, those are how I learned best. So I decided that I was going to get an MBA, and then discovered that Salem State College, was college then, had a part-time MBA program for people that were in the field. Went and talked to the person in charge of it, and who kind of spelled out all these distribution courses. Which I said, well, I'm a big shot management guy. I know numbers. I can read profit and loss statements. I don't really need any of that. He says, well, unfortunately, Mr. Kennard, you have to take these like basic courses in order to be in the program.
How old were you at the time?
I was probably in my late 20s. Okay. So I said, sure. So I was taking a basic accounting course, my first course. MBA course. I was going to get an MBA and an MSW, and that was my ticket. And almost immediately was completely lost. The basic notions of accounting were completely foreign to me, and ended up using my secretary, who was my secretary because she was in a work to welfare program. Or welfare to work program. So she was a woman with several kids who had been on welfare and now was given an opportunity to work for an organization, young woman, smart. But I would bring her my homework and say, I don't understand this. And she would tutor me at the front desk. This is how you do this. And the plus really means minus, but you really don't know this. And I'd bring her my tests. And I passed the course. But then decided that an MBA was perhaps not for me, and learn learn something about my own level of arrogance that served me well through the rest of my career. And I'm forever grateful to her for taking the time to help me.
Well, and for those of you who are listening who are under 30, a secretary is an old-fashioned way of saying administrative assistant. That's right. Right? Or office administrator, or
as I actually moved up in the nonprofit corporate world, I started with great secretaries and administrative assistant, and then no one.
Yeah. So I don't even think we use the word secretary anymore.
No, I think they're out. Yeah. She was a secretary. It was a classic. Yeah. So it was 1980s.
That's funny. So my original question of how did you get into this? I'm glad you went where you did, but it was social work, really. Yeah. I mean, how did you get into that? Social work. How did you leave high school and say, this is what I want to do?
I left high school. I've always loved history, and I left high school wanting to teach history. I was accepted because my uncle had a connection. I went to prep school into Tufts University. I would never get into Tufts University today, just as an aside, and as a history major. And there was a space of time between the semesters that you had to fill by doing some kind of independent study. And having no idea, I saw an advertisement on a bulletin board from a small residential school in Middletown, New York, that worked with, at the time, called mentally retarded adults, that was looking for someone to run their dining room. So I applied and got the job. Again, no experience in social work, no experience at population, and I loved it. Thrived, loved it. I ran a freaking dining room in the middle of this craziness. And this was in the middle of deinstitutionalization in New York. So these were all individuals living on this campus, this little community school and residential treatment center that had spent the majority of their lives in institutions. And it was a really remarkable time to be involved in that. And that really led me to, I left college for a year, worked there full time for a year, changed my major to child study, which I've never used. But I think that in combination with the fact that I was the oldest of 4 siblings and that I had a younger sister, my youngest sister, Katie, who was 12 years younger than I, was born with cystic fibrosis and died at the age of 17 in 1981, which had a profound impact on my life, and I think in many ways kind of guided me into this profession. So,
interesting.
That's how I got there.
Yeah. So let's go back to Project Cope.
Okay.
Which has merged with Bridgewell.
Yeah, so I had the opportunity to become executive director in 1998 after Dorothy retired. Served for close to 16 or 18 years there through some very interesting times. So through a lot of changes in how we think about addiction, how we treat addiction, how we fund addiction, but also the beginnings, and I say the beginning of the current opioid epidemic. I'm looking at 2000, 2004, somewhere in that area. So I had I was in the middle of kind of the pre-epidemic and the epidemic, and could really see. So when I would go out, I'd spent a lot of time in the community. My idea of when I became CEO was we were a small organization, always struggling for funding. I loved the smallness of it because we could try lots of different things. There weren't a lot of bureaucratic layers. If we could try it and get some money for it, let's do it. I love the creativity of small organizations. I love the loyalty of small organizations. People come, they feel a part of something, they want to stay, they feel like they have input, that they can make a difference. That's wonderful to me. We tried a lot of different things.
Well, it's a lot more experimental and experiential, right? You have this kind of attitude of like, well, I'd really like to try this. I've got some backing for it, maybe not financial, but I've got.
But it's a business, and you need to make money. Right. You need to take care of people. I mean, people's livelihoods are dependent on this, and the clients' futures are dependent on this. Yeah. And I think I learned at that process, I learned much more about addiction. And my understanding of addiction, I think, changed both in the course of just spending decades in the business, but also my personal journey, which was the realization that I was an alcoholic, and then having to deal with my own recovery during the same period of time. So there is kind of these institutional changes taking place as well as these personal changes taking place for me. And quite frankly, I think I've learned much more about addiction as a person in recovery than I ever have as an administrator or a social worker. So in terms of Project Cope, we did a lot of interesting things. We ran many kinds of prevention programs, outpatient programs, residential treatment programs, a lot of collaboration with community agencies, which I really felt was important. I really saw myself as kind of being the face of Cope because we were so small, that to identify me as kind of Cope made people think about our population. And really opioid epidemic, people weren't that interested. I mean, I can't tell you the number of times Ted Duchenne, the founder of Cope, and I would go out to do these talks, and nobody would come. Nobody would come.
Yeah, that's amazing.
No one was interested.
I mean, just compared to like some of the stuff that you and I have done, where there's 40 or 50 people in the room, you know?
And yet you match that with no one in the auditorium, and yet the constant conversations with either people trying to get in recovery or families of people calling, not knowing what to do, or in a panic, or the pain and what people who were suffering with this disease were going through. And it was such a chasm there because in many ways no one cared.
Yeah, well, which is interesting, right? That that you have this kind of timeline where, because of the opioid crisis, now people are taking interest, right? But I look at the numbers that I get of referrals for addiction or alcoholism, and a large percentage, significantly large percentage, is alcohol on the referrals, right? So not only has that gone up, right, and there's I have a whole kind of theory and speculation about why the rise in alcoholism and suicide too among guys,
especially middle-aged men.
You're in my age, right? I mean, you're a little past middle age, but I'm getting there. I'm creeping up.
Still got your hair.
I still have my hair, and so we're seeing a lot of because that was the thing when I took this job, and for the people listening, Mark and I go back a few years. And he was a big part of, I still blame him for this, and blame being the operative word. I still blame him for getting me into this whole thing with recovery coaching. And I know you're a little pressed for time because you have to babysit. You have a Manny position waiting for you.
I got a 1-year-old waiting for me.
Right, a little terrorist probably that just controls the whole day, which is wonderful.
Biggie.
And I have a couple things that I really want to get to. So if we could just kind of take a little.
Let me just finish the Cope story.
Sure.
Within 30 seconds. So we sold the property in North Common Street, the funeral home that Ted Duchenne and others had bought in 1970, and bought a vacant nursing home in Lynn. Because we really wanted to upgrade our residential facility for women, expand it, and to, quite frankly, create a more respectful, nice environment for them. So that's the plus part. The minus part was when I was doing all this was 2008, so the whole housing market collapsed. So we had to then put $1 million into this building to renovate it, and came out of that with my auditor sitting down with me and my finance committee, saying those words that no nonprofit director ever wants to hear. Mark, you better turn this ship around or it's going to sink. So we did. I mean, to our credit, we did turn the ship around. But the lasting result of that was that as a small nonprofit, community-based, always looking for money and always struggling for funding, it just was not sustainable. And so much of my energy as the CEO and my senior management team's energy was in money, not clients.
Right.
And so that's when we began to look for another partner. And we were very fortunate to develop a collaboration with Bridgewell, which is a well-known, much larger social service agency in the North Shore. We spent 2 years kind of talking. They were interested in us. They wanted to expand what they were doing in the addictions. They liked our brand. We wanted to make sure the cultural shift was right, because I remembered back in my North Shore children's days when the culture was really a problem. And we ended up merging in 2014. So
yeah, which is right about the time that you dragged me into this mess.
Correct. That was my second step once I merged, was I was going to find Richard Zombeck and I'm going to get him involved in this.
And torture him.
In case this whole thing goes south, I want him to be in the middle of it.
Actually, Mark approached me during around the time my father was dying. And I kept putting him off, and he kept trying to get me to go for coffee, and I would reschedule and then couldn't because I would go up to Maine. And my dad ended up dying pretty quickly from the time he was diagnosed. And Mark and I went out for a cup of coffee, and he told me about this. I'll let you talk about the project, but this new project that they were starting at Cope. And I sat there for at least 20 or 30 minutes saying, absolutely not. I am not going to do this. I do not want to do this. You can't make me do this. This is ridiculous. And the next thing I knew, I was getting my certification.
That's right.
And answering calls at the ED in Lynn, and working for Project Cope in Bridgewell with Wendy Kent and Jim Billings and a whole crew, and everything took off since then. So I'd like to hear about. I'd like to hear a lot about. I have a lot of questions for you, but I'd like to hear about how the Recovery Coach program, how that idea came up, and how you guys actually implemented it into Cope and into Lynn.
Okay. So again, just to go back to one of the central tenets of as I think about the opioid epidemic and treatment is that there, in my estimation, there needs to be as many opportunities as we can create for people to become involved in a system of care. So one of these, that this recovery coaching thing all of a sudden appeared on the radar screen. I'm not sure where it came from. I'm thinking somewhere on the West Coast, but I'm not entirely sure.
Well, I know you guys went down to Connecticut at a point.
We went to actually Rhode Island. So I'd heard about recovery coaching,
yeah.
began to read about it, and it was fascinating to me to be able to. So this is someone who's been in the field a long time professionally and now at this point had been in an active member in Alcoholics Anonymous for a long time. So it was in essence kind of a melding of those two worlds in a very interesting way, using people in recovery who would in fact use to some degree their personal recovery as tools to connect with someone who is actively using.
It's an incredibly novel approach.
So I said, this is really interesting. So you mentioned Wendy Kent. Wendy's a remarkable director of behavioral health, now working for Bridgewell, longtime clinical director for me. We took a trip down to Rhode Island where this anchor program, Rhode Island had instituted a program with all of their hospitals. I think there were 9 hospitals in the state where they had embedded recovery coaches in emergency departments. And for every overdose, a recovery coach would be called. There was this whole system of 24-hour on-call, would meet the ambulance and the person who'd overdosed at the ED.
So were they coaches that were on call, or were they embedded in the?
They
ED?
were on call. They were on call. So there was some embedding, but it was not within the actual hospitals. It was within this kind of more community program. And the idea was that they would just make themselves available to the person who was being stabilized medically to talk. Do you want to? This is who I am. I'm Mark. I'm a recovery coach. This is my experience. I know where you've been. I've been there. I've been lying on that gurney where you are. Can I be helpful to you? And okay, interesting. Then I began to look at some of their data. And what their data was showing was that between 70 and 80% of those initial engagements resulted in some kind of follow-up connection, whether it be a phone call, whether it be an appointment, whether it be some kind of connection to treatment, but something happened. So getting somebody at their worst, which is having their high taken away from him in a ED, resulted in a connection with a recovery coach and then some next step. Not that each one of these people got better right away or got into treatment right away, but there's some next step towards a recovery. And that really blew me away.
Well, and you guys at COPE were seeing the same fairly impressive numbers.
So we went back to North Shore Medical Center, of which we had a nice working relationship, and talked to them about, here's what's going on in your EDs, how you're handling people coming in. And they had all kinds of stories of getting completely overwhelmed in their 2 campuses with overdoses and often repeat overdoses, and the pain and the trauma the staff are going through with the overdose deaths of these young people. And the fact that they felt so helpless in terms of someone would come in dying, dead, or at death's door, be stabilized, and then 20 minutes, 45 minutes later be walking out of the ED, often AMA, and all they could really give them was a pamphlet of, here's some detoxes, you can call.
Yeah.
So they were frustrated about their own inability to do much and how to best help their staff and how to help better this client population. So we began to talk, and we introduced this recovery coach model. We spent a year virtually once a week talking about how to put this program together. And it's involved. There are lots of layers in that system. Buy-in was crucial from ED staff, from docs to nurses, the systems, how's the whole thing going to work. So it really took a year to work it all out. And In March, I think 2 years ago, we started the Recovery Coach ED program at Union Hospital, and with great success in terms of engagement. And then within the last, I think 6 months, it's expanded to Salem Hospital.
That was what?
Well.
That was 2017, right?
Correct.
Yeah.
Correct.
Yeah, because that's when I came on board there. Yeah.
So they embraced it, and they embraced it the way where they funded it. So the North Shore Medical Center has been not only a supporter in terms of staff, in terms of allowing us to work with them in the ED, but they have funded this initiative, and really, I think, has made a huge difference. So when someone comes into the ED now, their experience is very, very different than it was 3 years ago. Just as a quick side note, I wish I could say that was the case for every ED. I happened to spend some time in the ED on 2 days ago. I'm an avid runner and went into what has now been diagnosed as AFib during my run.
No kidding.
Ended up in a ED in New Hampshire where I now live. And you spend a few hours there. They're trying to get your heart back into normal rhythm. But I was talking to the nurse and doc there about, oh, geez, what do you do in New Hampshire? New Hampshire's had per capita, I think, the second worst state in terms of opioid deaths. What are you doing with people that are coming in who have been overdosed? And ultimately, the answer turned out to be they're giving them a pamphlet.
Yeah.
So as much
which is weird because here on the North Shore we have a huge recovery community, and if you go up to Maine, there's a huge recovery community, and you've got New Hampshire right in between the two of them that is just ripe with overdoses and deaths and
a huge recovery community.
And a huge recovery community.
So I'm not sure of all the variables, but it certainly suggests to me, the data says that there's still a lot of work to be done. On one level, Richard, it's incredibly frustrating to hear that and I said, I shouldn't have said it to the nurse, but I did, because even in my somewhat altered state, I was just enraged at, here we are in 2019, talking about giving people pamphlets in the emergency department.
Yeah.
And the fact that we have still remained unable to fully integrate the treatment of substance use disorders into the medical model is a source of great frustration for me.
Well, and there's some integration, right? I mean, there
Yes.
are doctors being trained in
Yes.
Suboxone. I mean, the French had it down back in the 90s where they just let every primary care physician prescribe Suboxone and buprenorphine. We're not there yet.
Correct.
You know, you have to be waivered, and you can only take on a certain amount of clients and patients, and it won't be the first time the French have beat us at something. But I'm a little biased. But what I'm curious about is, so we'll leave me out of the equation because you've recommended me or put me in contact with the two last jobs I've had, and I think both of the people that hired me have it out for you because of that. They're probably a little mad at you that you sent them Zombeck. But
I quickly retired and moved north.
Exactly, before any repercussions came your way. Because Steve and I have a lot of conversations about this, and also we're in a situation now too where we're eventually going to be looking for other people also. And so, when just starting out, just having this as a brand new thing, what were you looking for when you hired recovery coaches? I mean, what was the model that you were looking for?
I think that one is we wanted people who are interested in recovery coaching to be interested in the right reasons. I spent a stint as an adjunct faculty member at a local community college, part of which was spent managing the field placement program for the drug and alcohol treatment academic program. And in that, I spent a lot of time working with people that were in recovery that thought they wanted to be in the recovery field and that really shouldn't be in the recovery field. And much of my role was really to kind of talk them out of it. This was not a good idea for a variety of reasons. So I think one, to just gauge people's kind of why they were interested in doing this and kind of a little bit what their background was. Always made difficult by the fact that just the formal interview process is now so stilted and you can't ask so many questions. It's hard to get to some of that material.
Right.
But I think people that were open to lots of different treatments. Well, this worked for me, therefore it must work for you. There's no place for that in recovery
right.
coach.
Well, like William White advocates for the multiple pathways of recovery. Right.
So to be open to, let's have as many doors open as possible, and let's work with you to find a door that really works for you.
Yeah.
And it may not be doors 1 through 10, but there may be door 11. Not that kind of the old AA model, which is, we don't talk about drugs. Drugs is not appropriate.
So preferably someone that knows the system.
Well, knowing the system, but then really valuing the system
and act as a guide
right.
through those systems and towards any kind of treatment that is going to work for you. Right.
And to me, the basis of that is to respect the individual enough that you're working with, and to understand that there's a level of self-determination here.
Yeah.
And you can perceive it as misguided or not, but self-determination is really, really crucial in this process.
Well, and how hard was that to find?
Not as hard as I thought it might be.
Really?
There were many people that I found in recovery, and Wendy did most of this work, who were in other fields, completely other fields, but that had kind of always wanted to get involved in recovery, but had never found the right vehicle. And I think you're a good example of that.
I was in tech, and I was a newspaper reporter.
Right. So they'd been successful in something else, but there was still a part of them that really wanted to do something.
Well, and what's interesting, too, is that we all know about the stigma.
Right.
Right? So once you say that you're in recovery, that stigma is attached to you.
Right.
Right? Particularly in a clinical environment.
Right.
And what you did before, no matter how impressive it was, has no consequence.
Right.
It doesn't matter.
Right.
They don't care.
Right.
It's like, I tell my current boss now, it's like, yeah, the stigma is real.
Right.
I'm fortunate that I have a boss that's really good and understanding and lets me kind of go. She's spent endless hours listening to me rant, and she's probably really happy that I have a podcast now to do that. But so the other question on the recovery coach part, do you think, and this is a twofold question, and this is a question that we've been banding about on the podcast for a while, and Steve and I in car rides up to events or to work, is do you think it's necessary for a recovery coach to be in recovery?
Ooh, that's a good question. Necessary. I'm going to say yes, and I'm going to say that because the model, as I understand it, is predicated upon the person being in recovery.
Okay. So
there may be a different model that it would not be predicated. But this model is predicated on I have been there. To some degree, I have been there. I know. You don't have to explain this to me. I know what you're experiencing now. I know what you're feeling.
Okay.
Can I help? Can I be helpful to you?
Right. I know you've been there because I've been there.
Right. I certainly don't believe that a person not in recovery cannot be helpful to people in recovery. And I don't think anyone's saying that. But I think for recovery coach,
for this particular
yes.
job, I think
yes.
I think so also. I think it's the experience and your efficacy is only enhanced if you've had that experience. Now, the second part of that question, I didn't tell you it was a twofold question, is do you think length of time in recovery makes a difference? Now, I asked this because Steve and I have had many discussions about this, and also because the model that you saw in Rhode Island had a 6-year minimum.
Correct.
They wanted us, and I think you guys did a 5-year minimum, although you took a couple that were.
No, actually, I think the model in Rhode Island was 2 years minimum, if I remember. I could be wrong. But I believe it was 2 years.
Yeah, you might be right.
We decided to do 5 years.
You guys decided 5 or 6.
Right.
So why 5 or 6?
I think there were two things. One is just overall kind of, I think we understood and I don't know the length of time we define early recovery, but the challenges of recovery. And I think we were looking for people that had been kind of more stable in their recovery, that in many cases had already been doing something else, so had kind of reintegrated themselves as people in recovery and back into the workforce doing something.
So was this based on any evidence, or was this based on purely what you guys had known from being in the field?
Empirical evidence, no. Absolutely not.
Okay, because interestingly enough, there is now. There were recently a couple studies published that, and the stuff that we know too from being in AA and being in the recovery community, there are all these anecdotal kind of points of demarcation, right? These important milestones of a year, 3 years, 5 years that are important, and those have been clearly shown too to be real points that we can rely on, right? Not exactly 3 years or exactly 5 years, but there have been studies in Canada and England and the United States that show those, and that a 5-year period of time is a pretty clear indication that someone is serious about continuing their sobriety, right? So if you've made it to 5, so what I found interesting when I was hired by you guys was that point of 5 years, because having heard it anecdotally, I knew that it was a good number, right? Not that I knew, but we all think we know something, right? But it seemed like a good number. Like I thought you were doing something smart. And then even more recently, now that I'm in a position where I may be hiring people, coming across research that is empirical, that there are points and there is a 5-year marker to say when someone has reached 5 years in recovery, they tend to be, the percentage of them continuing, it becomes great exponentially, right? Is exponentially greater than prior to 5 years.
Okay.
And I also think, my argument with time, and you hear it all the time too, well, time doesn't matter, it's one day at a time. But time does matter. And if I'm listening to someone offer me suggestions about something, I want someone that's been doing it for a while, right? I'm not going to learn how to pitch a baseball from a little leaguer, a 14-year-old kid who's pitching ball. I want to learn it from the guy that's been pitching for the Red Sox for the last 15 years.
Interesting.
Okay, so that said, we are running out of time. I know you got to get up to your grandson and probably paint your toenails like baseballs again. That was great. I love that. I'll have to tell that story on the beginning of the end of this podcast or something, but if you don't mind.
Not at all.
I do have a question that I've been dying to ask you. I don't know why I never have. People who know you will know exactly what I'm talking about. The rest of the people are going to have an explanation, and I'll try to weave that in somewhere. But what the hell's up with the socks?
So I had a younger daughter graduated from college in 2008, and within a week had left the United States to go live in Holland. Now, there's a whole kind of backstory to this, but mostly involves a romantic relationship with a Dutch guy, and to be a nanny. So, and she lived the next 8 years in Holland, ended up marrying another Dutch man, having 2 children in Holland. So my wife and I were frequent visitors to Holland. And I began to notice that a lot of people in Holland wore these very colorful socks. So as I noticed them, I began to get them as gifts from her and her husband. So I began to wear them. And we had been nominated, Project COPE had been nominated for an award as Nonprofit of the Year by a trade association. So I went to accept the award in this big gala in some downtown hotel, and which was being emceed by a local news reporter. So I'm on this stage, hundreds of people, and I'm accepting the award, and she notices my socks. So she has me stand on stage and pull my pants up to show these multicolored socks. And the place goes crazy. And it kind of started this whole thing about me and these socks. So now I have a drawer full of these multicolored socks.
You must have a couple drawers full, because I've never seen the same one twice.
Which are, I have to say, have really caught on, because a lot of different people now are wearing those socks. But I think it's like so many other things, it then becomes kind of part of your identity.
Yeah.
I have dinner every week with my 94-year-old mother in an assisted living center. And there is a gentleman there, is an ex-prep school principal, who every Thursday night will come over to the table and with his cane point to my socks and say, good pair, a little off today. So the socks are a thing.
Well,
but an interesting thing.
Well, because here's the thing, right? Sometimes I bring you up in conversation, right? And they're like, Mark, what do you, I'm like, tall guy, bald, usually wears a jacket and tie. I don't know who you're talking about with the crazy socks. Oh yeah,
there
right?
you go.
And it is. It's a trademark thing. But
right.
I've known you for 5 or 6 years now, and I've never had the courage. I figured a microphone might, I could nail you down. But I've always wanted to know what the hell's up with the socks.
Socks.
So yeah, for those of you who don't know Mark or haven't seen him around, he always wears these really funky, colorful socks. And it's a cool thing. So listen, I know you got to go. I've already held you up longer than you agreed to. I want to thank you for coming down. I want to thank you for coming on the show. And that's it.
It's been my pleasure.
Thank you.
And I have to say, when I saw the Buds and Suds and listened to the initial episodes, I really am very impressed with what you and Stephen are doing here, and the work that you've done here, Richard. It's having a small part to play in what you have achieved professionally in the last 2 years, but to see what you have done really validates my initial thoughts about you, which is
I'm probably going to have to cut this whole part out.
Right, exactly. But it's really, I think it's very telling in terms of who the whole notion of who wants to work in this. With this population, and I'm sure you've heard it. I've heard it. God's work, or
we're saving
all
lives.
of this.
Yeah,
but I think for me, the interesting part about you and so many people in recovery is that they're smart, thoughtful, have a lot of experience, often can articulate themselves very well,
compassionate, kind.
Yeah, but I think that kind of often comes with people that are kind of in recovery.
Yeah, well, that's what I mean.
Yeah, but who kind of get it. But I think that, but also there's a part of them that is that looks at the system and wants to change it, and that isn't afraid to do that. And I think people that have undergone profound changes in their own life, a lot of that fear is no longer there. And I think someone like you and many others don't have the fear of being able to work within a system of care and understand that, but always be looking to change it and make it better. And to go back to my kind of underlying theme, such kind of harm reduction modalities as safe injection sites. Mm-hmm. It's criminal that we don't have safe injection sites in this state or in this country. It is criminal.
Most of the civilized world has them.
And it's criminal to me when I hear the mayor of Boston go to Canada and look at the sites and say, geez, this is interesting, but then come back and say, well, we don't really have the infrastructure to support this. Yeah. So when things are kind of politically just off the table because it's not politically sustainable or because of stigma or of all these other barriers, people are dying. 500,000 people have died from this in this country. This is an epidemic. And we use the word epidemic, but we don't kind of then take the next step. You try anything in an epidemic, anything. Yeah. It works. Yeah. And I still believe that our system of care has a long ways to go before really understanding what it's going to take to kind of deal with this epidemic. But I also believe, and this is kind of coming full circle, that people like you who aren't afraid to push those boundaries are going to be vital in that process. So for me, it was really it was great to be here and to talk with you.
Thoroughly embarrassing me is probably a good note to end this on. I'd love to have you back on some other topics. I'd like there are plenty of other topics we could talk about, particularly the recovery coach model and what else we can be doing. And you've always been an endless source of information for me. And so before we just both start patting each other on the back, I know you have to go. Thanks for coming on.
Thank you for the opportunity.
This has been another episode of Buds with Suds. Okay, that was Mark Kennard, former executive director of Project COPE and long-term addictions dude.
Mm-hmm.
What do you think, Steve?
Usually I get turned off by people that have multiple years working in recovery simply because how bad treatment services were, 60s and 70s. But I appreciated that he talked about, some of the changes, and especially I gravitated more towards the, the peer model that he started over at Project COPE and Bridgewell. And I found it interesting that he started off in, the therapeutic community treatment model, which I have gone through personally. There was a program that I attended for a number of months, and there's obviously pros and cons to all of that sort of treatment, but this breaking people down and to build them back up, it does a lot of harm. So I'm glad that treatment has, for the most part, moved away from that sort of approach. And also, I appreciate that he talked about the lived experience and how this role of peer support, you have to have lived experience, or he thinks you have to have it. I agree. Not everybody agrees. And I also think that, this idea of time equals stability and sobriety, I think is just nonsense. So those are some of the thoughts off the top of my head.
Yeah, we're gonna have to have a longer discussion at some point on that, because
sure.
You and I are in complete disagreement with that. But yeah, so in full disclosure, as most of you heard during the interview, Mark and I go back a little ways, at least a few years. He had approached me at some point right around the time my father had gotten sick, and asked me if I wanted to sit down and have a cup of coffee. And when I did, he brought up the whole idea of COPE and their new going into the ER, and I was completely opposed to doing that. And yet here, 3 years later, here I sit, a recovery coach and working in the field, which is something I never wanted to do.
Debatable if I even want to do it.
Yeah, I'm glad I did at this point. And at least for now, the thing with Mark that you touched on a little bit is I've run into a lot of people who know Mark, and I can't find anyone who had a single bad thing to say about him. I mean, everything was like, he's super kind. He's very, he's compassionate. One of the nicest guys I've ever met. Really cares. That, after being in the field for as long as he has, is an ultimate rarity. People tend to get jaded, and I've noticed that just talking to him too. When I had an incident or two that have happened, and I've run it by him, his stance was always on the side of the patient. It was always on the side of, why aren't we doing more? Why aren't we, what were they thinking when they did this? Why didn't they provide this? He's always looking out for people who are suffering, which I find particularly admirable. Particularly, as you and I know, we run into people constantly that have been doing this for a while and have just kind of lost all ability to care.
Yeah, and I think that's a bigger representation of the system that we're all working in. You know, I've been of the belief that it's not the people that are the problem, it's the systems that we've put in place and the silo nature that we work in. So, yeah, I mean, I appreciate it. You know, I appreciate somebody that has done this for 40 years and still has a generally positive attitude. And, you know, I wouldn't say sacrifice. I don't know. I'm sure there's been some sacrifice, but the story that he was talking about, I forget exactly where he was working, but, you know, when he decided to go to Lynn, and there was so much uproar or upheaval about leaving and go to work in Lynn with all those.
Yeah, he was working. He was working for a very prominent hospital, and took a job for probably a lot less pay and a lot less prestige, and decided that he actually wanted to do something. So, okay, so that was a pretty long interview, so we're not going to take up too much more of your time. Once again, this is Richard Zombeck and Steve Lesnikoski. We are Buds with Suds, and just want to mention too that all of the opinions expressed in this podcast are our own and of the guests that we have, and not the organizations for which we or they work.
Please don't fire me.